In September 2024, the United States Senate did something it hadn't done in over 50 years. It voted unanimously to hold an American CEO in criminal contempt of Congress. Not for fraud, not for a cover-up, but for refusing to explain what happened inside his hospitals. His name was Ralph de la Torre. While hospitals were struggling to stay operational, while nurses rationed gloves, while emergency rooms were overwhelmed, he was on a 190-foot private yacht, sailing through the Caribbean. And he didn't act alone. He was backed by one of the most powerful financial firms on Wall Street. And while hospitals began collapsing, patients were left without care, and thousands lost jobs. The money behind it had already been pulled out. This isn't a coincidence. It's a system. Hospitals became businesses. Patients became revenue. And the people who built that system don't live in it. So how did American healthcare get here? After 2008, investors searched for stability. Almost every industry collapsed, except one, healthcare. Because people don't stop getting sick, and the system keeps paying. Americans spend over $4 trillion a year on healthcare. To private equity, this wasn't medicine. It was predictable cash flow. So they moved in. Hospitals, nursing homes, ER staffing. Slowly, ownership began changing hands. But on the surface, nothing looked different. That's what made it invisible. Researchers describe a repeating pattern, a playbook, 4 steps. Step 1, debt loading. Hospitals are often bought using borrowed money, but the debt doesn't stay with investors. It gets pushed onto the hospital itself. Prospect Medical Holdings is one example. Debt rose from $450 million to $1.6 billion after acquisition. The hospital paid for its own takeover. Step 2, asset extraction. In some cases, hospitals sell their buildings after acquisition, then lease them back, meaning they now pay rent to exist in the same facility they once owned. A JAMA analysis found hospital asset values dropped significantly after acquisition. In Philadelphia, Hahnemann Hospital, 171 years old, was sold, stripped, and shut down within 2 years. Thousands lost jobs. A hospital erased from the system. Step 3, staffing pressure. Staffing is the biggest cost, and often the first to change. Studies have found reductions in nursing ratios and support staff in some cases after acquisitions. And when staffing drops, capacity drops with it. That's where pressure begins to show inside the system. Step 4, billing fragmentation. Some firms also control ER staffing companies, meaning you go to an in-network hospital, but the doctor treating you works for an out-of-network contractor. So you get a surprise bill, even when you followed every rule. Some analyses have found charges far above Medicare benchmarks. I had 14 patients and 1 aide. I kept thinking, if someone codes right now, I can't get there in time. Ralph de la Torre was a Harvard-trained heart surgeon. He became CEO of Steward Healthcare, a system of 30-plus hospitals across the US, backed by Cerberus Capital Management. By 2024, Steward was collapsing under billions in liabilities. Hospitals closed, services reduced, ERs strained. During this period, reports placed de la Torre frequently traveling internationally, including time aboard a private yacht. Meanwhile, hospitals in his system were struggling to function. Nurses reported shortages. Patients were being transferred in critical condition. The Senate issued subpoenas. He did not appear. They issued another. he still did not appear. In 2024, the Senate voted unanimously to hold him in contempt, a rare bipartisan action. He later stepped down. Investigations are still ongoing, and many of those hospitals have not recovered. Researchers have studied what happens after private equity enters hospitals. One major study found emergency room death rates increased by about 13% in the hospitals analysed. That translates into additional deaths per year in high-volume facilities. Other studies found no consistent improvement in quality, efficiency, or cost. A Stanford Law Review of the literature concluded, no clear evidence shows improvements in patient outcomes after private equity acquisition. In nursing homes, multiple studies have also found higher mortality in certain samples. Across the system, financial restructuring has been linked with staffing cuts and closures in some cases. And yet, fewer than 10% of acquisitions receive detailed regulatory review. So why does this keep expanding? Because healthcare is one of the largest industries in the world, and capital flows where rules allow it. In the US, private investment firms also spend heavily on lobbying and political influence. Healthcare decisions sit at the intersection of government, regulation, and private capital. Critics say this creates tension between profit and patient care. Supporters say it brings efficiency and investment. But the structure itself is clear. Ownership of healthcare has shifted dramatically in the last 20 years, and the system built around that shift is still evolving. And somewhere in America right now, a family is sitting in an emergency room waiting area. They don't know who owns the hospital. They don't know who is making decisions behind the doors. They don't know why the wait keeps getting longer. They only know something feels wrong, but nothing looks broken. The lights still work. The staff is still there. The system still responds when you call it. That's what makes it hard to see. It doesn't collapse. It continues. Millions of people walk into it every year thinking it exists to help them, not knowing the ownership behind it, not knowing the incentives shaping it. American healthcare didn't suddenly fail. It changed ownership. Quietly, legally, systematically. And most people never noticed. By the time you do, you're already inside it. Because sometimes, a system doesn't need to hide if it already feels normal.